Half initial topic present in handwritten notes. File goals: prevent rebleeding, maintain adequate cerebral perfusion, avoid secondary brain injury, facilitate prompt diagnosis and treatment, preoperative management, assessment, clinical severity. Hunt and Hess grading, WFNS scale, consciousness level, focal deficits, comorbidities. Control hypertension, aim for SBP, 160 mmHg unless poor cerebral perfusion suspected. Prevent rebleeding, early aneurysm securing clipping coiling. Manage hydrocephalus, external ventricular drain, EVD, if needed. Correct coagulopathy, reverse anticoagulants if present. ICP management, head-up position, avoid hypoxia and hypercapnia. Anticonvulsants may be given to prevent seizures. Intraoperative management, monitoring, standard ASA monitoring plus arterial line, central line if required. Consider ICP monitoring if EVD present. Induction, smooth, avoid surges and BPI. Agents, propofol or etomidate, stable hemodynamics. Short-acting opioids to blunt sympathetic response. Airway, secure airway, minimize coughing or bucking. Maintenance, balanced anesthesia, inhalational or TIVA. Maintain normocapnia, PACO 235-40 mmHg. Avoid hypo or hypertension. Use vasopressors inotropes if needed to maintain CPP cerebral perfusion pressure. Fluids, maintain euvolemia, use isotonic crystalloids. Avoid glucose-containing solutions. Temperature, maintain normothermia. Brain relaxation, mannitol or hypertonic saline if required, only with surgical coordination during aneurysm clipping, may require transient controlled hypotension, with careful titration. Burst suppression with propofol may be used in critical periods. Emergence, smooth and controlled. Avoid coughing, hypertension, and hypercapnia. Deep extubation may be considered if airway safe. Postoperative care, monitor for vasospasm, usually days 3-14 post-bleed. Continue nimodipine, Ca to the power of 2 channel blocker to reduce delayed ischemia risk. Maintain euvolemia and adequate blood pressure. Frequent neurological monitoring. Summary crux line, for Viva, anesthetic management of SAH aims to prevent rebleeding, maintain cerebral perfusion, control ICP, and provide smooth induction and emergence, while closely monitoring neurological and hemodynamic status. Fat embolism. Fat embolism is the blockage of blood vessels by fat droplets, usually occurring after major trauma like long bone fractures or orthopedic surgery. Can happen within 2 to 3 days after major bone break or trauma. GERD criteria, major criteria, 1 necessary for diagnosis, 1. Respiratory insufficiency hypoxemia, POW2, 60 mmHg, 2. Cerebral involvement disproportionate to hypoxia 3. Petechial rash axillary or subconjunctival, minor criteria, 4 necessary for diagnosis, 1. HR, 120 beats min 2. Fever 3. Retinal changes fat or petechiae 4. Renal signs anuria or oliguria 5. Anemia 6. Thrombocytopenia 7 ESR. 8. Fat globules. Symptoms include respiratory insufficiency, mental state changes, tachycardia, HR, vision changes, jaundice, fever, petechial rash. Pathophysiology of fat embolism, fracture, trauma, intramedullary reaming, intramedullary pressure injury, opening of venous sinusoids, translocation of fat, and then fat may enter 2 circulations, pulmonary circulation via right heart, lungs, mechanical obstruction and or inflammatory response, VQ mismatch, POW2 SAO2 Ardzali, respiratory failure, acute pulmonary hypertension, PHT, right heart failure, RHF, systemic circulation via patent foramen ovale or lung capillary bypass, effects, mechanical obstruction and or inflammatory response leading to brain CNS depression, kidney oliguria, renal ischemia, heart myocardial ischemia, infarction, eyes, retinal hemorrhages, skin, petechial rash. In short, fat escapes into blood after trauma, blocks small vessels, causes both mechanical blockage and inflammatory damage affecting lungs, mostly, and other organs, brain, kidney, heart, skin, eyes. Differential diagnosis for fat embolism investigations, ABGs to guide ventilation management, management of fat embolism syndrome. Main principle, supportive care, there is no specific antidote. Key steps. 1. Airway and breathing, oxygen supplementation, target SPO2, 90%, mechanical ventilation if severe hypoxia ARDS develops. 2. Circulation, IV fluids to maintain perfusion, avoid overload. Vasopressors if hypotension despite fluids. 3. Monitoring, continuous SPO2, ECG, BP, ABGs to monitor gas exchange. 4. Early fracture fixation, stabilize fractures early to reduce further fat release. 5. Corticosteroids, controversial, some protocols suggest steroids may reduce inflammation and hypoxia, but evidence is weak, not routinely recommended. 6. DVT prophylaxis, LMWH once bleeding risk is controlled. 7. General supportive care, ICU care if severe. Treat complications e.g., ARDS, sepsis. One-liner to memorize, ABC support, early fracture fixation, ICU if severe. Scoliosis definition. Scoliosis is an abnormal lateral sideways curvature of the spine, forming an S or C shape. Onset, birth, childhood, or adolescence, 10-15 years. Types, congenital neuromuscular idiopathic most common, 65%. Neuromuscular scoliosis occurs due to weakness or dysfunction of muscles or nerves that normally stabilize the spine. Examples include cerebral palsy, muscular dystrophy, spinal cord injury, and spina bifida. Advanced disease. Severe scoliosis can cause organ dysfunction, lungs, heart, GI, and chronic pain. Note, kyphosis refers to exaggerated anterior-posterior curvature. Pathologic forward bending. Preoperative evaluation. Assess for significant pulmonary, cardiac, and neurological comorbidities. Right-sided thoracic curvature. 7-10 vertebrae is common. Left-sided curvature raises suspicion of congenital anomalies. Spinal cord, gastrointestinal, cardiac, pulmonary function. The severity of pulmonary impairment depends on cause, comorbidities, and degree. Location of curvature. Look for dyspnea and inability to cough effectively. Increased risk of infections. Likely restrictive lung disease pattern. Reduced lung volumes. Poor ventilation. Consequences: hypercarbia, hypoxemia, and increased risk of pulmonary infections. Investigations: spirometry, PFTs, ABGs, severe disease, pulmonary function tests, PFTs, FEV1, FVC, normal FEV1/FVC ratio, restrictive pattern, total lung capacity, TLC, residual volume RV usually maintained. Plain X-ray radiographs of the spine, Cobb angle. Cobb angle measures the severity of spinal curvature, 45 to 50 degrees. Surgical correction indicated, 70 degrees. High postoperative complication rates, 100 degrees. Severe cardiopulmonary dysfunction. Cardiac effects. Severe scoliosis can lead to cardiac disease, RHF, or cardiomyopathy in Duchenne. Mechanisms: chronic hypoventilation, hypercarbia plus hypoxemia, pulmonary hypertension, right heart failure, neuromuscular scoliosis e.g. Duchenne muscular dystrophy, may cause dilated cardiomyopathy. Mitral valve prolapse is seen in 85% of children with scoliosis. Clinical signs to assess: exercise intolerance, jugular venous distension, hepatic congestion, peripheral edema. Investigations: ECG, echocardiography, echo, to evaluate cardiac function. Others: blood CP to evaluate for anemia. Non-idiopathic scoliosis. Common causes: cerebral palsy, Duchenne muscular dystrophy, mitochondrial myopathies. These patients often have complex comorbidities. Careful preoperative evaluation and record review are essential. One-liner for Viva recall. Scoliosis causes restrictive lung disease and cardiac dysfunction through hypoventilation, pulmonary hypertension, and myocardial strain. Preoperative preparation for scoliosis surgery. Correct anemia. Optimize hemoglobin to improve oxygen carrying capacity. Optimize nutrition, ensure good nutritional status for healing and recovery. Optimize cardiovascular and pulmonary function, treat heart or lung issues preoperatively, ensure best baseline. Assess and document neurological status, baseline neuroexam critical before spinal surgery. Notify blood bank, arrange blood products, expect significant blood loss. Pre-book ICU or HDU bed, plan post-operative care in high dependency or intensive care unit if needed. Surgical approach: posterior spinal fusion. Adjustable rods, younger children; fixed rods, older children. Anterior thoraco-abdominal approach, removal of discs. Vertebrae combined approach, posterior plus anterior. Intraoperative management goal is to avoid hypoxia, hypercarbia, hypotension, hypothermia, and blood loss. Thoracic vertebral involvement may need one lung ventilation. OLV, monitoring and positioning, standard monitors, ECG, NIBP, SPO2, ECHO2, temperature, urine output. Arterial line, for ABG and sampling. Central venous access if major fluid shifts expected. Anticipate difficult IV access in syndromic children. Monitor and avoid pulmonary cardiovascular dysfunction, positioning challenges, prone position, protect pressure points, use chest rolls, free abdomen, maintain eye protection, avoid raised eye pressure, temperature management, large exposed surface area, risk of hypothermia. Management, warmed IV fluids, forced air warming blankets, maintain ambient room temperature, hemorrhage management, expect significant blood loss up to 50% of blood volume. Plan, preoperative iron erythropoietin EPO, autologous blood donation, hemodilution, intraop, cell saver, induced hypotension. Careful, risk of spinal or visual ischemia, use dynamic cardiac output monitors if available. Multimodal analgesia, essential to reduce opioid requirement and enhance recovery. Includes acetaminophen, paracetamol, NSAIDs. Careful if bleeding risk. Gabapentin, neuropathic pain control. Ketamine, low-dose infusion if needed. Opioids IV, PCA, or epidural route, epidural catheter common. Neurological monitoring. Goal, detect spinal cord dysfunction in real time. SSEP, somatosensory evoked potentials, stimulate peripheral nerves, measure cortex dorsal column tract. MEP, motor evoked potentials, stimulate motor cortex, measure muscle response, corticospinal tracts. Signal changes equals possible spinal ischemia, notify surgeon immediately. TIVA, total IV anesthesia preferred if SSEP MEP monitoring planned. Important, high-dose inhalational agents, 0.7 to 1 mAh, suppress evoked potentials. Neuromuscular blockade affects MEPs. One-liner for Viva recall. Scoliosis surgery requires careful monitoring for bleeding, ventilation issues, hypothermia, and spinal cord protection using SSEP MEP. Wake-up test. Used if no neuromonitoring available, performed intraoperatively to assess motor function. Patient is lightened from anesthesia and asked to follow commands, e.g., move fingers, toes. If patient obeys commands, deepen anesthesia and complete surgery. If patient fails to move, alert surgeon. Possible spinal cord ischemia, extubation planning, pre-op FEV1, 40% predicted, high risk for poor respiratory effort, plan postoperative ventilation. VC or FEV1, 70% predicted, safe for immediate extubation post-surgery, respiratory function, severe cases worsen the pre-existing or baseline restrictive lung disease. Immediate improvement after spinal correction is unlikely. Anticipate postoperative atelectasis, possible need for postoperative ventilation, neuromuscular disease, higher ventilation needs, postoperative complications, scoliosis surgery, general complications, neurological deficits. Iatrogenic injury to spine, need for ventilatory support, more likely in severe disease. Spinal correction does not immediately improve pre-existing restrictive lung dysfunction. Postoperative visual loss, rare but serious. Types: ischemic optic neuropathy, central retinal artery occlusion. Risk factors: long surgeries, prone positioning, hypotension, anemia. One-liner for Viva recall. Post-op risks include pulmonary dysfunction, ventilation need, pain control issues, and rare visual loss. Wake-up test checks spinal cord function intraoperatively. Intraoperative management. Quick recap: surgical approach. Posterior anterior combined standard monitors plus Artline plus or minus CVP, difficult IV access, syndromic kids, protect pressure points, prone position, maintain normothermia, forced air warmers, warmed fluids, expect major blood loss, cell saver. Induced hypotension, carefully neuromonitoring, SSEP plus MEP, prefer TIVA, avoid deep inhalational anesthesia, 0.7 to 1 mAh, avoid neuromuscular blockade, affects MEP postoperative plan. Severe disease equals high risk for prolonged ventilation, pre-op FEV1, 40% planned ventilation, pre-op VC FEV1, 70% immediate extubation, multimodal analgesia, PCM, NSAIDs, opioids, epidural, watch for post-op visual loss, rare but serious. Special, wake-up test, no neuromonitoring available, lighten anesthesia, patient obeys commands, deepen and continue surgery, author Weilert, surgeon. Anesthesia outside the operating theater. Final premium summary, WFSAA source. Introduction. Increasing procedures outside OR-EG, radiology, endoscopy, cath lab. These areas often lack or-level facilities, higher patient safety risk, specific risks in remote locations, unfamiliar environment and staff. Limited access to patient airway and monitors. Sicker patients, Sadia3/IV. Equipment and emergency backup often inadequate. Planning and preparation. Site survey. Visit the location beforehand. Confirm space, access, emergency exits. Equipment check, full standard monitoring available. Ensure oxygen, suction, anesthetic machine, airway cart, and backup power. Emergency plan, no resuscitation protocols. Emergency drugs and defibrillator must be accessible. Staffing, an experienced anesthesiologist must be involved. A trained assistant skilled in airway management should be present throughout. Patient selection and preoperative assessment. Standard ASA preoperative evaluation applies. Check fasting status. Patients with major comorbidities or airway risks consider moving procedure to the OR. Monitoring standards, ECG, pulse oximetry, non-invasive BP echo 2, if sedation airway support planned. Defibrillator and airway rescue tools must be readily available. Equipment requirements, equipment and monitoring must match OR standards. MRI, use non-ferromagnetic anesthesia machines and devices. Backup power source must be present. Environmental factors, adequate lighting and working space. Full access to patient at all times, airway and IV access, anesthetic challenges in specific locations, radiology CT, MRI, remote patient location delay in intervention possible. Long breathing circuits risk of hypoventilation. MRI, ferromagnetic safety critical, use MRI compatible devices, endoscopy suites, shared airway with endoscope increases airway obstruction risk. Risk of aspiration, secure airway when deep sedation GA needed. Difficult patient positioning e.g., lateral, prone, may hinder airway access. Cardiology, cath lab, sudden hemodynamic changes common, due to balloon inflation, arrhythmias. Risk of contrast nephropathy. Side, pacemakers ICDs precautions required. Radiotherapy centers, often require repeated anesthesia for young children. Usually short GA or deep sedation with minimal airway intervention. Full resuscitation setup still mandatory. Sedation outside the OR. Sedation is a continuum, can rapidly deepen to GA. Main risk, loss of airway protection. Full monitoring and airway rescue preparedness is mandatory. ECHO 2 monitoring essential if deep sedation given. Post-procedure recovery. Recovery standards equals OR standards. Monitor until fully awake. Protecting airway. Hemodynamically stable. Trained recovery staff must be present. Key principles to remember. Standards of anesthesia care must remain identical to or never compromise on. Monitoring airway management, resuscitation readiness, recovery care. If safe conditions are not possible, relocate patient to OR. One line crux for Viva. Anesthesia outside the OR demands full or equivalent preparation. Monitoring, airway control, emergency planning, and safe recovery facilities. Understanding magnetic resonance imaging. Introduction principle of MRI. MRI magnetic resonance imaging visualizes body tissues based on atomic behavior in a magnetic field. Focuses on hydrogen nuclei, abundant in water and fat. When placed in a strong magnetic field, hydrogen protons align. A radio frequency pulse disturbs them. When they relax back, they emit radio signals detected and converted into images. Soft tissues show different relaxation times, giving excellent contrast between brain, muscles, tendons, vessels, magnet and shielding. MRI magnets are superconductors, cooled with liquid helium below 4.2 Kelvin. Common field strength equals 0.2 to 3.0 Tesla. Research MRI up to 7 Tesla. Room is enclosed in a Faraday cage to block external radio frequency interference, preserves image quality. Gradient coils create spatial localization and produce the characteristic loud knocking noise during scans. Because of rapid switching magnetic fields, safety zones. MRI departments are divided into zones based on magnetic field strength, shown on next page. 5 Gauss line, weak but sufficient to interfere with pacemakers. 50 Gauss line, risk of strong magnetic pull projectile effect, see next table. Indications for MRI. MRI is gold standard for imaging soft tissues. Common indications: neurology, brain tumors, stroke, multiple sclerosis MS, spinal cord lesions. Cardiology, cardiac structure. MRI-compatible pacemakers now exist. Myocarditis. Musculoskeletal, ligament injuries, cartilage damage, soft tissue tumors. Oncology, soft tissue cancers, metastasis detection. CT remains superior for acute bone fractures, intracranial hemorrhages, especially hyperacute blood, some abdominal emergencies e.g., bowel perforation, hazards and safety, projectile injury. Any ferromagnetic object becomes a dangerous missile. Burns, heated wires or cables can burn patient skin, especially ECG leads. Monitoring cables. ECG, Sadia3 changes not reliable due to electromagnetic interference. ECHO 2, increased transit time of 20 seconds, sampling to graphical display, acoustic injury, MRI noise, 85-100 dB mandatory ear protection. Vertigo flashing lights, due to movement inside changing magnetic fields. Implant issues, pacemakers, aneurysm clips, metallic foreign bodies, serious risks unless MRI compatible, monitoring and equipment, only MR safe or MR conditional devices allowed inside MRI. Special ventilators, infusion pumps, monitors needed. Non-compatible equipment, image artifacts, burns, mechanical failure, projectiles and even equipment malfunction. Anesthesia considerations, anesthesia usually induced outside MRI room. Airway security is critical, limited access inside scanner. Metal check repeated after induction. TIVA preferred, infusion pumps placed outside control area if possible. Rest of the concerns similar to NORA, emergency management, resuscitation inside scanner impossible. Patient must be pulled out to zone 2 or 1. Defibrillators and emergency trolleys stay outside scanner room. Special points, quenching and its hazards. Why does quenching happen in MRI? MRI magnets are superconducting, they must stay extremely cold, around 4 Kelvin, or -269 degrees Celsius, using liquid helium. Superconductivity equals zero electrical resistance, allowing a continuous magnetic field. Quenching happens when the magnet warms up accidentally or intentionally. Manual shutdown in emergency, loss of extreme cold, loss of superconductivity. When superconductivity is lost, the electrical resistance suddenly appears. This resistance causes huge heat production, boiling the helium, and helium gas expands massively. Result, rapid expansion of helium gas, pressure buildup, risk of room oxygen displacement, need for emergency venting. Risk, released helium can displace oxygen, risk of asphyxiation if venting is inadequate. Safety measures, proper helium vent pipes must be installed to direct gas safely outside. Staff must be trained to recognize and respond to quench events immediately. Scavenging of anesthetic gases in MRI, volatile agents, like sevoflurane, and nitrous oxide can be safely used inside MRI suites. Requirement, must use MRI-compatible anesthesia machines with proper scavenging systems. Why scavenging is needed? To prevent accumulation of anesthetic gases in the workplace air, protect staff health. Follows workplace safety regulations to avoid chronic exposure. Pregnancy, avoid MRI in first trimester unless absolutely necessary. Gadolini contrast risks, rare but possible nephrogenic systemic fibrosis, mainly in severe renal failure. Post-op MRI, safe in most modern implants but always check implant documentation first. Conclusion, MRI is extremely safe when basic screening, metal checks, and equipment protocols are strictly followed. Always plan for airway access and emergencies before entering Zone 4. Learning tip, focus on 5 main headings. Principal magnet plus shielding, safety zones, indications, hazards. Revise these first. 80% of exam questions will come from these. Laser surgery, laser, acronym, light amplification by stimulated emission of radiation. Laser provides high energy density with the ability to rapidly transfer large amounts of energy to remote sites. Energy delivery, through fiber optic channels, e.g., KTP laser, or free air, e.g., CO2 laser. Characteristics of laser radiation, high energy density due to monochromaticity, single wavelength. Coherent emission, oscillating in phase. Collimated beam, focused, narrow. Advantages of laser. 1. High precision in airway surgeries. 2. Invisible beam, e.g., CO2 laser, provides unobstructed view during resection. 3. Minimal bleeding and edema. 4. Preservation of surrounding structures. 5. Rapid healing. Disadvantages. 1. Eye damage, from corneal injury to retinal scarring. 2. Airway fire, laser heats absorbent materials, major risk in airway laser surgery. 3. Cutaneous burns, from deflected laser beams. 4. Laser smoke plume, carries vaporized cancer cells and virus particles. Risk of lung damage and interstitial pneumonitis if inhaled. General precautions during laser surgery. 1. All OR personnel and patient must wear laser-specific goggles with side protection. 2. Tape and shield patient's eyes. 3. Keep flammable materials away from laser path. 4. Apply wet towels over exposed skin to prevent burns. 5. Use special surgical masks for filtering laser smoke. Special airway precaution, use flexible, stainless steel, laser-resistant and if possible, commonly used medical lasers, CO2 laser, far infrared, long wavelength. Superficial penetration vaporizes surface tissue with minimal deep damage. Use laryngeal papillomas, laryngeal webs, hemangiomas, ND, YAG laser, near infrared, deeper penetration 2-6 mm. Very powerful. Use prostate surgery, deep airway papillomatosis coagulation, argon laser, blue or green light, 0.5 to 2 mm penetration. Highly absorbed by hemoglobin, good for vascular lesions. Helium neon laser, red light, used for aiming beams. Anesthetic techniques for laser surgery. Goal: immobilize patient. Keep airway secured. Clear surgical field for laser. Preferred technique: general anesthesia GA with ET, laser-resistant tube if possible. Apneic technique, preferred by some surgeons in airway surgery on infants, small children. Advantage: open, unobstructed surgical field, no ET blocking view. Disadvantage: airway trauma, desaturation risk. Technique: deep anesthesia plus or minus muscle relaxant used to prevent movement. Child anesthetized, immobile, ventilated intermittently via face mask between laser applications by the surgeon. Jet ventilation, laser surgery context. Jet ventilation is a modification of the apneic technique, delivering oxygen without traditional endotracheal intubation. Jet ventilator delivers high-pressure oxygen via a narrow-bore catheter inserted into the trachea or through the operating laryngoscope fitted with a variable pressure-reducing valve. Technique: induction via volatile agents in oxygen-air mix or TIVA, e.g., propofol, dexmedetomidine. Spontaneous breathing is maintained initially. Jet ventilation is then delivered through a catheter after anesthesia deepens. Advantages: no ET obstructing the surgical field, better access for laser surgery. Open airway view, critical in airway laser surgeries. Disadvantages: no complete airway control. Laryngospasm risk, as airway reflexes may not be suppressed. Difficulty scavenging anesthetic gases and surgical smoke. Risk of barotrauma, if expiration impaired. Limited protection from aspiration. Important note: surgical laryngoscopes fitted with side ports allow gas exit during jet ventilation, reduces barotrauma risk. Surgical staff must be alert to prevent gas trapping. Jet ventilation provides a tubeless field, but risks include aspiration, barotrauma, and poor airway protection. One-liner for Viva recall: laser surgery offers high precision but carries risks of airway fire, eye injury, and smoke inhalation. Safety protocols are crucial. Airway fire. 1. Introduction. Key principle: prevention, management. Anesthesia team must be aware that airway fire can occur. Identify high-risk situations. Allocate clear goals and roles. Be ready for immediate action. 2. Fire triangle. 3 essential elements: ignition source, laser, electrocautery, fiber optic light, high-speed drills, defibrillator. Fuel: alcohol prep, drapes, gowns, gauze, ET, patient's hairskin. Oxidizer: oxygen, nitrous oxide. 3. Prevention strategies. A. Ignition source management. Safe electrocautery use. Prefer bipolar. Avoid cautery during tracheal incisions. Proceed only if FiO2, 30 to 40%. Safe laser use. Use lowest effective power, short pulse. Deactivate before removal from surgical site. Hold away from ET bronchoscope before activation. Instruments should be matte, not reflective. B. Minimize oxidizer enrichment. Avoid N2O and keep FiO2 as low as safely possible. Stop oxygen supplementation 1 minute before cautery laser. Good communication between surgeon and anesthetist is needed. Prefer cuffed ET filled with normal saline or methylene blue to detect cuff rupture. Use laser-resistant ET or double cuffed ET. C. Control fuel sources. Use tubeless techniques when possible. Allow alcohol-based preps to dry completely before draping. Apply water-soluble gel to patient's hair and skin. Moisten gauze, pledgets, throat packs with water or saline. 4. Management of airway fire. Immediate, coordinated response. 1. Announce fire loudly. 2. Stop procedure. Surgeon stops laser cautery and removes ET. 3. Anesthetist, stop all gases immediately and disconnect breathing circuit. 4. Extinguish fire, flood with saline. 5. Remove burnt debris and ET fragments. Next steps of care: assess severity of airway injury. Prefer rigid bronchoscopy, over flexible. Monitor for 24 hours and provide ventilatory support. Provide humidified oxygen and dexamethasone. Severe cases: low tracheostomy may be needed. Inspect ET for residual fragments. Report adverse event as per protocol. Family counseling. 5. Special focus, endotracheal tubes and laser surgery. NOET is 100% fireproof, but risks can be minimized. 6. Managing surgical smoke evacuation system, vacuum pump plus filters plus suction hose plus gas inlet nozzle. Room suction systems, much lower efficiency, less preferred. Quick one-liners to remember: key to airway fire, prevent ignition, minimize oxidizer, remove fuel. If fire occurs, shout stop gases, extinguish, remove debris, ventilate, evaluate airway. Strabismus surgery procedure, extraocular muscle surgery performed to correct squint, either unilateral or bilateral. Typically a daycare procedure. Time, approximately 60 to 90 minutes. Pain, usually mild. Position, supine position. Blood loss, minimal to none. Anesthetic techniques: LMA with spontaneous ventilation preferred if aspiration risk is low, or endotracheal tube, ET, ray or armored tube, with intermittent positive pressure ventilation IPPV, if indicated. Patient population, mainly children. Preoperative assessment and goals: establish rapport with both the child and the parents, especially the mother. Assess the child for anesthesia fitness. Discuss anesthesia options including induction technique, IV or inhalational, and plan for postoperative pain management. Answer any questions asked by the parents to relieve anxiety. Address and manage anxiety of both the child and the parents. Key information to obtain from mother: obtain full medical and anesthetic history. Detailed birth checks and ask about NICU stay, congenital anomalies, respiratory issues. Checks of developmental milestones and recent vaccination history. Checks of recent resp tract infections. Evaluate the need for sedative premedication based on the child's anxiety level. Obtain consent for anesthesia and explain the possibility of rectal analgesia. Children's fasting guidelines: children are positively encouraged to have clear fluids up to 2 hours before surgery. Prevents dehydration and hypoglycemia, both of which are more common and dangerous in fasting children than the risk of potential aspiration. Behavioral assessment: although most history can be gathered from the mother, useful assessment can also be made by observing the child's interaction, behavior, and physical status from a distance to ensure it is appropriate for the child's developmental stage. Information to give to mother. This applies to all pediatric surgeries. Provide a brief explanation of the journey through the treatment complex. Explain what will happen if the child becomes upset, including failed cannulation, alternative plans. Inform them about who will escort the child from the anesthetic room. Discuss the details of postoperative course and analgesia, including the possible use of suppositories. Guide about NPO: nothing by mouth instructions. Solids: formula milk up to 6 hours, breast milk up to 4 hours, clear fluids up to 2 hours. Other methods of explaining anesthesia: use of leaflets, videos, and preoperative clinics to enhance understanding. Associations with squint: cerebral palsy, Down syndrome, Noonan's syndrome, cardiac defects, difficult intubation, platelet and coagulation defects, renal dysfunction, hydrocephalus, malignant hyperthermia. Anesthetic management: intraop, establish routine monitoring, obtain IV access, consider pre-use of EMLA cream, 1.5 to 2 mg/kg. Induction with inhalational agents or IV agents like propofol, 2-3 mg/kg. Maintain airway with LMA preferred, or AT if indicated. Maintenance of anesthesia with either spontaneous ventilation and air oxygen sevoflurane, or controlled ventilation if necessary. Multimodal analgesia approach using regular paracetamol both intraoperative and postoperative. Minimize use of opioids to reduce risk of PONV, postoperative nausea and vomiting. PONV prophylaxis using combination therapy, e.g., ondansetron 0.1 mg/kg and dexamethasone 0.1 mg/kg. Prevention of hypothermia. Maintain good hydration with IV fluids, may help reduce incidence of PONV. Specific management considerations: succinylcholine should be avoided as it increases ocular tone for up to 20 minutes, making surgical correction difficult and impairing force duction testing. Careful control of intraocular pressure and monitoring of end-tidal CO2 is important. Consider controlled ventilation, especially if using volatile anesthetics, to ensure sufficient depth of anesthesia to achieve a neutral eye position. Propofol may preserve eye position better and allow faster recovery compared to volatile agents. Always be vigilant for the occurrence of oculocardiac reflex (OCR). Oculocardiac reflex (OCR) definition: a trigeminal vagal reflex triggered by traction on extraocular muscles or pressure on the eyeball, leading to bradycardia. arrhythmias, and possibly even asystole or ventricular fibrillation, triggers pressure on the eyeball. Traction on extraocular muscles, especially medial rectus. Strabismus surgery itself. Administration of retrobulbar block, pathway afferent limb, ophthalmic division of trigeminal nerve, reticular formation, vagal motor nucleus. Efferent limb, vagus nerve, heart SA node. Clinical features: nausea, vomiting, bradycardia, arrhythmias in severe cases, asystole or other serious cardiac arrhythmias. Prevention: maintain deep inhalational anesthesia. Maintain normocapnia. Use of retrobulbar block, though it may also trigger reflex in some cases. Use of IV prophylactic anticholinergics e.g., atropine or glycopyrrolate, may be considered, but with caution, especially in patients with CAD or IHD. Management of OCR1. Immediate notification to surgeon and cessation of surgical stimulus until heart rate recovers. 2. Administration of IV atropine, 10-20 mcg/kg, if bradycardia persists. 3. Confirm adequate ventilation, oxygenation, and depth of anesthesia. 4. If episodes are refractory, infiltration of the rectus muscle with local anesthetic may be considered. Special notes: be mindful that strabismus surgery is associated with a high risk of PONV. Proactive management is crucial. Always be prepared for a sudden OCR event at any stage during surgery, especially during muscle traction. Penetrating eye injury issues and management. 1. Risk of intraocular content extrusion. If intraocular pressure IOP rises, it can cause expulsion of eye contents and permanent vision loss. 2. Risk of aspiration. Emergency anesthesia may be needed in a full stomach patient. Aspiration risk. Determinants of intraocular pressure IOP. Normal IOP 12-20 mmHg. Transient IOP increases with, in adults, coughing, vomiting, valsalva, posturing. In children, crying, eye rubbing, breath holding. Effective cardiovascular and respiratory parameters: raised IOP with increased CVP, arterial BP, hypercarbia. Reduced IOP with hypocarbia. Effective anesthetic drugs on IOP increase IOP. Succinylcholine raises IOP by 5-10 mmHg for 5 to 10 minutes. Ketamine, historically, though controversial, decrease IOP. Volatile anesthetics: Sevo, ESO, Desiv anesthetics, propofol, thiopentone. Benzodiazepines, opioids, non-depolarizing muscle relaxants, NDNMB. Note: succinylcholine increases IOP by causing prolonged contraction of extraocular muscles, rich in motor endplates. Factors affecting IOP during anesthesia: factors increasing IOP, external compression, tight face mask. Straining during laryngoscopy. Factors decreasing IOP, smooth induction, adequate muscle relaxation, NDNMB. Induction agents: propofol. Head up tilt by 15 degrees. Moderate hypocapnia, PACO 230-35 mmHg. Strategies to prevent IOP rise: avoid external pressure on globe. Avoid pharmacological agents that raise IOP, e.g., succinylcholine. Avoid coughing, bucking during intubation, extubation. Maintain deep anesthesia and normocapnia. Gentle laryngoscopy. Deep extubation. Why regional anesthesia not preferred? Reasons. 1. Distortion of anatomy, difficulty in targeting LA accurately. 2. Risk of increased IOP from large orbital LA volume. 3. Patient anxiety and inability to remain still. 4. Risk of infection from open eye wound. Anesthetic management plan. Preoperative detailed assessment of injury, associated injuries, airway, other comorbids and previous anesthesia. HX. Pre-medication, IV oral metoclopramide and H2 blockers, ranitidine, 0.3 m 30 ml sodium citrate orally to neutralize gastric acid. Intraoperative monitoring, standard monitoring, ECG, SPO2, NIBP, ETCO2. Pre-oxygenate with 100% oxygen, make ARA to avoid direct pressure on the eye. Technique: induction agent, propofol with adjuncts, fentanyl 2 mcg/kg, lidocaine 1.5 mg/kg before intubation. Perform classical RSI with succinylcholine or modified RSI using rocuronium 0.8 to 1 mg/kg if SUX is contraindicated. Careful use of cricoid pressure. Ensure adequate depth and relaxation before attempting laryngoscopy to prevent rise in IOP if succinylcholine is used. Blunt IOP surge by pretreatment with NDNMB, small dose. Remifentanil bolus immediately before laryngoscopy. Intubate with a soft, flexible ray tube. Ventilate with IPPV. Goals of intraop management: avoid factors that increase IOP, maintain oxygenation, normocapnia, normothermia and good analgesia. Prophylaxis for PONV is crucial in this case. Extubation, deep extubation to prevent emergence coughing. If deep extubation is not hazardous for the patient, postoperative aim, avoid IOP rise. Gentle extubation, deep extubation preferred if safe. Good postoperative analgesia, prefer opioid sparing. Head up tilt 15 to 20 degrees to enhance venous drainage and reduce IOP. Avoid coughing bucking during emergence. Special key points: always balance the need to minimize IOP rise against the risk of aspiration. Succinylmethonium use should be individualized depending on airway difficulty and aspiration risk. Good teamwork between anesthesia and ophthalmic surgery team is essential. Eye blocks. Anatomy of the orbit. Bony orbit houses the eye and extraocular muscles. Pyramid-shaped, base anterior, apex posterior toward middle cranial fossa. Extraocular muscles. 6 muscles control eye movements. 4 recti: superior, inferior, medial, lateral +2 obliques: superior, inferior. Recti converge at apex. Annulus of Zinn, connective tissue blends sensory supply fibers into sclera, nerve supply. So 4 LR6, rest by 3 superior oblique by CNIV, lateral rectus by CN6, others by CN3, ciliary ganglion. Lies within muscle cone. Receives sensory fibers from V1 ophthalmic division. Parasympathetic fibers from CN3. Sympathetic fibers from carotid plexus. Short ciliary nerves arise and enter globe. Ophthalmic anesthesia overview. Retrobulbar block. Intraconal, injection into muscle cone. Steep, deep needle insertion. Low volume 1-3 ml. Rapid dense anesthesia and akinesia. May need separate facial nerve block for folded akinesia. Complications: globe perforation. Brainstem anesthesia via optic nerve sheath. Retrobulbar hemorrhage. Intraarterial injection, seizures, apnea, peribulbar block, extraconal, injection outside the muscle cone. More superficial, less risky. Higher volume needed, 4-10 ml. Slower onset of anesthesia and akinesia. Facial block usually not needed. May supplement with medial canthus injection. Technique: IV access and monitoring mandatory. Preferred in anxious uncooperative patients. Topical and infiltration anesthesia, used for surface surgeries e.g., cataract extraction. Topical drops: proparacaine, short-acting. Lidocaine, longer duration if gel used. Risks: corneal toxicity with overuse, incomplete anesthesia. Subconjunctival injection, LA injected under conjunctiva. Improves depth of anesthesia. Intracameral injection, by surgeon directly into anterior chamber during surgery. Spleen and splenectomy. Functions of the spleen: immune response, formation of plasma cells and lymphocytes, phagocytosis, hematopoiesis and fetus lymphopoiesis throughout life, storage of RBCs, 8% of circulating RBCs stored in spleen. Splenectomy indications: 1. Trauma, commonest organ injured in blunt abdominal trauma associated with rib fractures. 2. Hypersplenism, hereditary spherocytosis, immune thrombocytopenic purpura, IDP, thalassemia. 3. Tumors, lymphomas, leukemias, myeloproliferative disorders. 4. Other causes: splenic cysts, splenic abscesses, hydatid cyst. Surgical approach: laparoscopic technique, commonly used. Open technique in cases of massive splenomegaly. Preoperative planning. 1. Understanding the disease state, basic knowledge of underlying hematological disease. 2. Hematologist liaison to manage specific aspects of patient's condition. 3. Preoperative assessment, routine major surgery assessment including evaluation of anemia and thrombocytopenia, systemic complications of chemotherapy or malignancy. 4. Specialized blood products, irradiated or HLA matched if required. 5. Preoperative interventions, e.g., splenic artery embolization in select cases, like refractory IDP. 6. Multidisciplinary collaborative approach. 7. Platelet count considerations: if platelet count 20,000 or platelet transfusion needed in IDP, steroids or IVIG before surgery. Platelet transfusion should be avoided before surgery to prevent sequestration in spleen. 8. Vaccination schedule: address pre-splenectomy vaccination needs. Perioperative care: anesthetic management focused on underlying hematological condition, coagulopathy risk, and bleeding tendency. Steroid replacement if chronically dependent patient. Surgical approach: laparoscopic or open midline laparotomy for emergency trauma. Left subcostal incision for hematological problems. Other considerations: antibiotic prophylaxis plus nasogastric tube insertion. Care of pressure points during positioning. Plan for massive blood loss. Cell saver if available. Hemodynamic management. Monitoring invasive BP. Monitoring fluid management crucial in sickle cell disease and spherocytosis to prevent crises. Aseptic measures. Temperature regulation. What is OPSI? Overwhelming post-splenectomy infections, infection with encapsulated bacteria. High mortality. Common organisms, Streptococcus pneumoniae, Neisseria meningitis, Haemophilus influenzae. Prevention of OPSI. 1. Antibiotic prophylaxis. Penicillin, amoxicillin. Lifelong continued at least up to 16 years of age. 2. Immunization. Vaccinate against pneumococcus, influenza, and meningococcus ideally 2 weeks prior to planned surgery. Immediately postoperatively if emergent splenectomy. Repeat vaccines every 5 years. Major concerns. 1. Perioperative coagulation abnormalities. 2. Intraoperative massive hemorrhage. 3. Post-splenectomy infections. Gastrointestinal surgical procedures, APR, abdominoperineal resection, procedure. Complete removal of distal colon, sigmoid colon, rectum, and anal sphincter complex via anterior abdominal and perineal incisions. Permanent colostomy. Open or laparoscopic approach. Open technique, abdominal incision from pubic symphysis to just above the umbilicus. Extend cephalad if needed. Patient position. 1. 2. Team approach with patient in lithotomy position, legs placed in stirrups well padded. 2. Modified lithotomy. Reposition to prone jackknife or lateral decubitus for perineal portion of surgery. Indications. Anal cancer, rectal adenocarcinoma within 4 to 6 cm of anal verge. Recurrent anorectal fistula. Extensive tissue destruction not responding to conservative management. Personnel. Surgeon, surgical assistant, anesthetist, urologic assistant in patients requiring extensive resection and for ureteral stent placement. Gynecological assistance, females. Vaginal or uterine manipulation or palpation. Complications. Wound infection. Postoperative ileus ureteral injury. Stoma-related complications. Hemicolectomy. Indications. Colon cancer most common. Inflammatory bowel disease. Perforation or obstruction of colon. Complicated appendicitis involving appendix base. Cecum. Colonic polyps with malignant potential. Technique, open or laparoscopic. Can be right or left hemicolectomy. Right hemicolectomy procedure. Resection includes cecum appendix ascending colon hepatic flexure extent, limited right hemicolectomy up to hepatic flexure, extended right hemicolectomy up to mid. Transverse colon position. Laparoscopic supine. Open supine, Trendelenburg with right lateral tilt incision, midline, 8 cm, above and below umbilicus or right paramedian. Left hemicolectomy. Resection from mid-transverse colon. Splenic flexure, descending colon, sigmoid colon position. Laparoscopic. Trendelenburg with left lateral tilt. Open supine, usually. Complications. Anastomotic leak. Ureteric injury. Conversion to open from laparoscopic. Hartmann's procedure. Resection of rectosigmoid colon with creation of a colostomy. Proctosigmoidectomy. Indications. Complicated diverticulitis most common, rectosigmoid cancer. Emergency, obstruction, perforation, or elective. Palliative care, perforation, ischemia, volvulus, trauma, ulcerative colitis. Approach, open or laparoscopic. Hartmann's reversal. Closure of colostomy with formation of colorectal anastomosis. Open or laparoscopic. Whipple's procedure. Pancreaticoduodenectomy. Description. Complex surgery, removal of pancreatic head, duodenum, gallbladder, bile duct plus or minus gastric antrum followed by reconstruction to restore GI continuity. 3 reconstructions. 1. Pancreaticojejunostomy. 2. Hepaticojejunostomy. 3. Duodenojejunostomy. Indications. Tumors of pancreatic head. Uncinate process. Pancreatic ductal adenocarcinoma. Periampullary carcinoma. Duodenal adenocarcinomas. Pancreatic neuroendocrine tumors. Chronic pancreatitis. Severe pancreatic trauma. Resectability based on radiographic criteria. Resectable, radiographic clearance, borderline resectable, unresectable, distant metastasis, major vessel involvement. Complications. Pancreatic fistula. Bile leaks. Bleeding at hepaticojejunostomy. Exocrine endocrine insufficiency. Delayed gastric emptying. Hyperthermic intraperitoneal chemotherapy procedure. Cytoreductive surgery plus heated chemotherapy. Infusion into peritoneal cavity. Steps. 1. Cytoreduction, complete removal of visible tumors, open laparotomy. 2. HIPAC, circulation of heated chemotherapeutic agent, 41 to 43 degrees Celsius, for 60 to 90 minutes. E.g., mitomycin C, cisplatin. Indications. Pseudomyxoma, peritoneal metastasis, from colorectal, ovarian, gastric cancers. Mucinous neoplasm of appendix peritoneal mesothelioma. Pacemakers. Classification of pacemakers. 5-letter code system describes permanent pacemaker characteristics. Pacemaker. 5-letter code, plain text version, position I, chamber paced. 0 none A atrium V ventricle D dual, atrium plus ventricle, position 2, chamber sensed. 0 none A atrium V ventricle D dual, position 3, response to sensing. 0 none T triggered I inhibited D dual, both triggered and inhibited, position IV. Programmability. Rate modulation. 0 no programmability. R rate modulation. Pacemaker adjusts pacing based on activity physiology, position V, and tachycardia pacing. 0 none A atrium V ventricle D dual, atrium plus ventricle, North American Society of Pacing and Electrophysiology, NASP, and British Pacing and Electrophysiology Group, BPEG. Classification, CRT. Cardiac resynchronization therapy, biventricular pacing to improve cardiac performance and heart failure. Generally responds to lead movement or atrial ventricular synchronization, ICDs, implantable cardioverter defibrillators, complex, tailored devices for patient-specific needs. Key pre-op concerns when anesthetizing a patient with PPM1. Patient factors. Indication for pacemaker. Comorbid cardiac conditions. Underlying cardiac function. Patient's long-term use of anticoagulants. 2. Pacemaker factors. Age and type. Pacemaker or ICD manufacturer. Device details. Serial number. Date of last pacemaker check. 3. Surgical factors. Use of diathermy. Surgical site. Proximity to pacemaker. Anesthesia for patient with pacemaker. Preoperative. 1. Identify original indication for insertion. Type of pacemaker. Date of last check. Programmed functions. Rate response. Antitachycardia modes. ICD shocks. 2. Look for symptoms suggesting pacemaker malfunction. Syncope. Palpitations. 3. Deactivate rate responsive or antitachycardia modes if needed. 4. Check pacemaker function, ECG, CXR to identify position lead integrity. 5. Check electrolytes, especially potassium, hypokalemia, risk of ventricular instability. 6. Cardiology opinion if needed. 7. Review antiarrhythmic drugs. Some drugs, e.g., digoxin, hypothermia, can affect pacemaker capture. Intraoperative. 1. Appropriate monitoring, based on pre-op assessment. Alternative pacing means ready external, transcutaneous, transesophageal. 2. Cautious induction, avoid drugs altering myocardial conduction. Etomidate, succinylcholine, ketamine preferred if concerned. 3. Volatile agents, avoid large alterations, can alter pacing thresholds. 4. Avoid hypoxemia, hypercarbia, prevent ectopy and arrhythmias. 5. For rate-responsive pacemakers, minimize transthoracic impedance to prevent inappropriate rate increase. Diathermy. 6. Cautions, can reprogram PPM, risk of microshock or VF. Program pacemaker to asynchronous mode if needed. Use bipolar cautery preferred. If unipolar, must be used. Plate kept away from heart, short bursts, cables routed away from pacemaker, magnet use. 7. Generally avoided, only emergency use. May inhibit stimulation depending on device programming. Defibrillation. 8. If cardioversion defibrillation required, place paddles perpendicular to pacing wire. Avoid passing current through pacemaker leads. Special measures. 9. Peripheral nerve stimulators may interfere with pacemaker sensing. 10. Isoproterenol may be needed as a temporary measure until external pacing achieved. If pacemaker fails, postoperative check pacemaker function. Reprogram pacemaker as needed after surgery. Problems with the pacemaker: failure to pace. Definition: no electrical output at the pacing wire tips when the set pacing mode calls for an output. Reasons: lead malfunction, unstable connections, insufficient power, battery depletion, needs battery change, cross inhibition, oversensing, failure to capture. Definition: electrical output is present at the pacing wire tips. Visible pacing spikes on ECG, but no mechanical cardiac contraction occurs, evidenced by absence of arterial pulse, blood pressure waveform, or mechanical cardiac impulse. Reasons: increased resistance at the wire myocardium interface, fibrosis around pacemaker lead, most common. Note: failure to capture is the commonest problem encountered with temporary epicardial pacing. Management: increase output first, correct electrolytes, confirm lead position, PONV prophylaxis, identify risk factors, APFL score, easy mnemonic, FENS, female gender, emetogenic history, PONV or motion sickness, none. Smoker surgery with opioids. Post-op opioid use. Each factor equals +1 risk point. Basic principles. High-risk patients. Multimodal prophylaxis. Use 2 or more drugs. Timing matters. Some drugs best given at induction, some before end of surgery. Drugs used. Classes and examples. 5-HT3 antagonists. Examples include ondansetron and granisetron. They block serotonin receptors involved in vomiting pathways. Ondansetron is considered the gold standard for PONV prophylaxis. Corticosteroids. The main drug used is dexamethasone. It is most effective when given at induction of anesthesia. It has an antiemetic effect, probably by reducing inflammation and prostaglandin production. NK1 receptor antagonists. Aprepitant is the commonly used drug in this class. It is useful in very high-risk patients and works by blocking the neurokinin 1 receptor, another key player in nausea and vomiting. Dopamine antagonists. Drugs like droperidol and metoclopramide fall into this group. Droperidol is potent but associated with QT prolongation risks. Metoclopramide is less effective compared to other antiemetics but still used sometimes. Antihistamines. Dimenhydrinate is an example. It blocks histamine H1 receptors, helpful mainly for motion sickness-related nausea but less commonly used in standard PONV prophylaxis today. Anticholinergic. Scopolamine, especially in the form of a transdermal patch, can be used. It is particularly effective for preventing motion sickness-related PONV and should be applied preoperatively as it takes a few hours to work. Non-pharmacological measures minimize volatile anesthetics. Tiva is preferred. Avoid nitrous oxide use. Regional anesthesia if possible. Adequate hydration. Avoid dehydration. Minimize opioid use. Use multimodal analgesia. When to give prophylaxis. Dexamethasone at induction. Ondansetron 30 minutes before end of surgery. Scopolamine patch pre-op takes a few hours. Rescue therapy. If PONV occurs despite prophylaxis, use a drug from a different class than already given. Quick 2-line strategy for exams. Assess risk. Give multimodal prophylaxis. Different rescue drug if failed. Example PONV regimen for high risk at induction. Dexamethasone 4 mg IV before end. Ondansetron 4 mg IV plus. Avoid N2O. Minimize opioids. Maintain hydration. One-liner for Viva. In high risk patients, I will prefer Tiva. Avoid N2O. And give multimodal antiemetic prophylaxis like dexamethasone plus ondansetron. Rescue with a different class if PONV occurs. Pulmonary edema. Definition: abnormal accumulation of intravascular fluid in lung parenchyma, leading to diminished gas exchange at the alveolar level and causing respiratory failure. Classification: broadly classified into cardiogenic and non-cardiogenic pulmonary edema. Cardiogenic: volume overload pulmonary edema due to increased pulmonary capillary hydrostatic pressure secondary to elevated pulmonary venous pressure. Causes: excessive volume administration, left ventricular systolic or diastolic dysfunction e.g., myocardial infarction, cardiomyopathy, arrhythmias, pulmonary venous outflow obstruction e.g., mitral stenosis. Non-cardiogenic pulmonary edema caused by lung injury with a resultant increase in pulmonary vascular permeability, leading to movement of protein-rich fluid into alveolar and interstitial compartments. Causes: Alliards, pneumonia, inhalational injury, acute pancreatitis, sepsis, burns, severe trauma, shock, multiple blood transfusions, allergic reactions, aspiration, near drowning. Neurogenic pulmonary edema: any acute CNS insult can result in pulmonary edema. A CNS event produces dramatic change in Starling forces, increasing fluid flow across capillaries and interstitium. Both cardiogenic and non-cardiogenic components contribute. Most common cause: subarachnoid hemorrhage. Other causes: traumatic brain injury, TBI, seizures, cerebral hemorrhage, meningitis, encephalitis. Mechanism in SAH: neurogenic pulmonary edema 1. SAH: increased intracranial pressure, sympathetic activation 2. Pulmonary vasoconstriction plus systemic vasoconstriction 3. Pulmonary venous pressure 4. Shift of blood from systemic circulation into pulmonary circulation 5. Results: pulmonary capillary pressure, pulmonary capillary permeability, left ventricular compliance 6. Leads to neurogenic pulmonary edema, negative pressure pulmonary edema caused by forceful inspiration against a closed glottis e.g., laryngospasm. Marked negative intrathoracic pressure, -20 to -140 cm H2O. Inspiratory phase: negative pressure leads to venous return to right heart, pulmonary blood volume, hydrostatic pressure, transudation of fluid from capillaries to alveoli. Expiratory phase, with closed glottis autopeep develops prevents fluid from leaving pulmonary capillaries and from entering alveoli. Relief of laryngospasm, sudden drop in airway pressure fluid floods alveoli severe acute pulmonary edema. Diagnosis of pulmonary edema clinical signs wheezing pink frothy sputum fine crepitations, crackles, gallop rhythm S3. Elevated JVP liver engorgement investigations chest X-ray, basal shadowing bat's wing appearance perihilar haze bronchial cuffing curly B lines ECG, evidence of right heart strain myocardial ischemia arrhythmias. Management of pulmonary edema immediate management ABC resuscitation principles depends on patient's current state. If awake and breathing spontaneously, sit the patient upright, semi-Fowler's position, high flow oxygen, 100%. Via reservoir bag mask improve pulmonary vascular unloading consider CPAP 5-10 cm H2O use vasodilators if hypertensive e.g., GDN sublingual, IV GDN if arterial line available, if anesthetized and intubated, IPPV with PEEP. 5-10 cm H2O head up position, 15 degrees, dry the lungs, dry therapies, aspirate fluid intermittently from endotracheal tube subsequent management optimize fluid therapy, using serial CVP or PAOP measurements. Treat underlying cause consider inotropic support e.g., dobutamine, or norepinephrine if needed. Fluid pressures must be kept optimized to ensure adequate circulation. Cerebral palsy CP child, what is cerebral palsy? Group of non-progressive disorders of motion and posture. Result from injury to the developing brain during antenatal, perinatal, or postnatal period. Clinical picture varies from high-functioning mild monoplegia to severe spastic quadriplegia with mental retardation. Intellect can range from normal to impaired. Etiology multifactorial injury to developing brain, perinatal hypoxia prenatal infection e.g., torch infections genetic predisposition congenital abnormalities trauma. Classification. Swedish classification, based on neurological dysfunction and extremity involvement, spastic, most common, quadriplegia diplegia hemiplegia dyskinetic, dystonia chorea athetosis ataxic mixed. Common surgical procedures orthopedic, osteotomies, soft tissue release, tendon transfer dental, extractions gastrostomy imaging studies sedation needs, other, neurosurgery urology and eye procedures. Clinical problems and comorbidities 1. Central nervous system epilepsy visual and or hearing defects behavioral disorders intellectual impairment communication problems 2. Cardiovascular chronic lung disease pulmonary hypertension, RV hypertrophy, or cardiac failure difficult vascular access, due to multiple cannulations, contractures. 3. Respiratory recurrent respiratory infections pulmonary aspiration risk, poor cough, secretion retention chronic lung disease scoliosis restrictive lung defect poor nutritional status impaired immunity 4. Airway potentially difficult laryngoscopy, poor dentition TMJ dysfunction positioning difficulties 5. Gastrointestinal, GI, increased incidence of GERD esophageal dysmotility spasm abnormal lower esophageal sphincter function swallowing difficulties risk of dehydration, malnutrition, electrolyte imbalance, anemia 6. Allergies, latex allergy, due to repeated medical exposure 7. Medications chronic use, antiepileptics antispasmodics e.g., baclofen, prokinetics, perioperative management preoperative 1. Prepare patient and parents, anxiety common worsened by communication barriers. Involve primary caregiver during induction and recovery 2. Consent, clear explanation of risks and benefits 3. Pre-medication sedatives balance benefit versus risk, airway compromise. Antacids, anticholinergics, reduce oral secretions. 4. Additional measures emlacrimid IV sites. Continue anticonvulsants. Consider pre-op physiotherapy, bronchodilators if needed. Intraoperative 1. Monitoring routine ASA monitors. Temperature monitoring mandatory, high risk of hypothermia. Depth of anesthesia MAC, altered responses possible. Neuromuscular monitoring risk of altered NMB response. Increased doses needed due upregulation of H receptors 2. Vascular access, difficult access consider ultrasound guidance 3. Airway management anticipate difficult airway. Excessive secretions reflux frequent suctioning. Consider cuffed based on age and aspiration risk 4. Positioning and pressure ulcer prevention, extreme care in fragile joints, spastic limbs. 5. Temperature regulation, hypothermia common forced air warmers, warm IV fluids, humidified gases 6. Drug responses may have increased MAC for volatiles, resistance to non-depolarizing muscle relaxants, NDNMBs. Avoid epileptogenic drugs e.g., enflurane, etomidate 7. Regional techniques recommended for intra- and postoperative pain management. Postoperative 1. Emergence problems, delayed emergence, hypothermia, residual volatile effects, excessive secretions, airway compromise, frequent suctioning, risk of aspiration, require careful monitoring. 2. Pain management, pain assessment, challenging caregiver input, critical multimodal analgesia preferred. 3. Anticonvulsant seizure management, continue regular anticonvulsants. Manage spasms, baclofen, diazepam. 4. Pressure ulcers, risk due to immobility and poor nutrition, reposition frequently. 5. Respiratory care, chest physiotherapy, high risk of poor respiratory function, postoperative ventilation or tracheostomy if needed. 6. Constipation, CP, children prone due to immobility and opioid analgesia, laxatives as needed. Key perioperative challenges: seizure control, respiratory function optimization, GERD management, pain and spasm management, PONV management, effective communication, multidisciplinary team approach involving surgeon, pediatrician, anesthetist, physiotherapist, speech pathologist, specialized nursing services, acute pain services. Laparoscopic cholecystectomy, problems associated with anesthetizing